Good afternoon, everyone, and welcome to the Behavioral Health Eco Series. Happy Friday to everybody. Nice being here with such a great group of people. Very excited about today's session. But before we start, I want to remind you that this session is being recorded and you may find it later at our Be Well Texas YouTube page. The information you see on the chat will not appear on the recordings, so please we invite you to continue adding your names, email addresses, and organizations on the chat. We will use this information to confirm your attendance, but if you're joining via phone, you may also send an email at cstat@utesca.edu so we can associate your phone numbers with your names. And today we have Dr. Lesley Manson presenting on tips and tricks for behavioral health interventions. After that, we'll opening the floor for your questions. And then during the second part of the session, as usual, we're going to have a case discussion. And this time it's going to be particularly interesting because we're having Aisha Olson is giving us an update of a case that we discussed back in January. So it's certainly going to be exciting to see the progress and the changes in the case. And for now, we're going to start with some introductions from the Behavioral Health Hub. Dr. Antoine, welcome to Behavioral Health Echo.
Great to be here. Good to see everyone. I'm Dr. Dennis Antoine, coming from Baltimore, Maryland, where I work at Johns Hopkins Baby Medical Center with the Center for Addiction and Pregnancy, and also Cornerstone Clinic at Helping a Mission. I'm a addiction psychiatrist stationed there. So good to see everybody.
Welcome, Dr. Antoine. Didi, welcome to the session.
Good morning here from California. I'm Dee Dee Stout, and I am in Emeryville, California, outside Berkeley or Oakland, whichever you prefer, the home of Pixar Studios. Yoo-hoo! I have a private practice here where I see individuals and families, all having to do with some substance use, not necessarily substance use disorder, but that also happens. I am also an associate professor at St. Mary's College in Moraga, California. And thank you very much.
Thank you, Didi. And our case presenter, Aisha, welcome back to Behavioral Health. How are you today?
I'm doing great. Happy to be here. Thank you.
Thank you. Jasmine.
Hello, everyone. My name is Jasmine Vidal, and I'm the program coordinator for our Behavioral Health Echo Session. Thank you for joining us today.
Thank you, Jasmine. And last, Dr. Lesley Manson, if you could briefly introduce yourself. And I think that after that, we can start with your didactics.
Oh, wonderful. Thank you, Andrea. Hi, everybody. I'm Lesley Manson. I'm a clinical psychologist, and I'm also a consultant for integrated behavioral healthcare. I provide consultation in the United States, Canada, and in the EU. I also have a clinical professorship at Arizona State University. I also help lead specific degrees and programmatic changes related to that. So that's just a little bit of a brief intro, but I will say I'm in 113 degrees in Arizona right now. Just because I heard where everybody else is, and Dee Dee, I'm jealous right now, being in California, play nice and cool. Hopefully enjoying those breezes. So thank you, everybody. Yeah, that's right, it's hot. But I'm sure in Texas it's hot there too right now. So we're gonna jump in. I'm gonna go ahead and show you my screen. Does everybody see my screen okay? Okay, thank you.
Yes, we see it.
Okay. I'm going to go ahead and dive in. I know we don't have a lot of time. I tried to be brief, but what I love to do is as everyone's going through this today, if you have any questions, feel free to go ahead and put them in the chat box, or feel free to unmute your microphone and let me know. Obviously, there'll also be time at the end, but I love to be able to see if folks have specific questions as I'm moving through today. Today's topic is tricks and tips for effective telebehavioral health interventions. And so I want to note that I do not have any financial disclosures to note for CE purposes. And today I'm going to be going over some strategies related to improving engagement in telehealth. We're also going to be talking about how to adapt sometimes interventions related to that. And I'm going to talk a little bit about some technological challenges and things that people might want to do to consider preparing for telehealth. These slides will also be available for folks, so if you'd like to look at them, you'll be able to have them as well. So just kind of setting the stage, I think these first couple slides I'm going to go through fairly quickly because we all probably know the benefits of telehealth by now, right? We know that it has significantly expanded access. And originally, back in the 80s and 90s, and in fact, the early 2000s, we were already doing telebehavioral health, but it was actually in very specific closed networks. And so it was looked a lot different. However, the research still was pretty good as far as indicating that people had a lot of satisfaction and we were able to increase access. Now, with expansion of obviously the internet and the expansion of cell phones and cell phone services, which is actually one of the predominant devices that is used in telehealth and telebehavioral health connections for our patients, we've been able to see a significant increase in utilization, and we see it with satisfaction. Originally, there was a lot of concerns that obviously individuals, say older individuals or specific children, may not have a lot of high utilization or high satisfaction, in which case we've actually seen that they do. Now, there is a population for children, of young children, that we do say it is best to be in person for play therapy. And however, we also know if they do not have that access, then it is better than not having access. So just to be very clear when it comes to that. When we look at some of the research and look at engagement of that, we are looking at this transition at about 12 years and up, sometimes going down to 10 years and up related to telebehavioral health success. So anything that might be under that, the recommendation is still to do it in person as much as possible, or what we're starting to do now, which is hybrid engagement. And so I'll talk to a little bit about that as we move forward. But again, a lot of reasons why people are doing it, inclusive of also low cost and patient preference. We're seeing now, especially with specific age areas, our teens and 20-year-olds now seeing that they prefer telesessions over in-person sessions. Now, there's also a lot of research wondering about why that could be, and a lot of debate in the research related to that, and just kind of normalizing that a little bit. That also comes into play when it comes into other types of research about how specific age groups are having different types of comfort when related to interpersonal interaction, and their comfort is dominant on interaction through a media or a tele, of some kind. So whether it be telephone, texting, or interaction through a video system. So that's coming into play, and just so everybody to be aware of, which is why hybrid pieces are now starting to be recommended. Okay. As I move through this, I'm also going to do shout outs to AI and talk a little bit about that toward the end. And I welcome questions related to AI and telepractices as well. So we have some great research that's out there. We also have some real new research, but I put some of the standing research that says, hey, we've got some great research on veterans, older adults, children, adolescents, related to their support of it, the efficacy of it, when it comes to patient outcomes, but also the cost effectiveness of it as well. But anytime we're starting to look at this, we want to make sure that we're setting up our practices well. Okay, so we want to make sure that we're doing specific things. So language and visual aids are really important. In fact, what we're recognizing now is that for a very specific large age group, so it's literally 30 and under, what we're seeing is that it is more relevant for them to have visual images without a lot of words than it is to have words. So even in our universities, the recommendation is actually to reduce the amount of words that we use and rather go through infographics. Now, again, we can all debate about what that means or what that looks like or what we believe should happen in those areas, but just to note what we are seeing related to research and what we know regarding learning is happening. So the recommendation is if you are really reaching out to those populations and seeing them in practice, really consider running your current NPPs, your current consent forms, all of those pieces through infographics. It doesn't mean you don't have our legal paperwork and all of those things, but you have them duly noted. You also want to be able to have them that is able to be distributed online, so through other types of platforms or EHR engagement. So that's really important to consider. And then in your paperwork, you do want to update all of your paperwork if you're doing any type of tele engagement with folks to note all of that, inclusive of noting any concerns related to connectivity issues, privacy issues, and platform concerns. So all of that needs to be documented in all of your paperwork, but then also within pre-visit or the first visit, those things should be communicated verbally and walk through with each person so that there is a plan involved of what to do if this occurs. Now, if you are part of a healthcare system, this could be something that is done through another individual. It could be a medical assistant, it could be the front desk, it could be someone else that might be the kind of head of telehealth for you that goes through that with your patients. If you are your only person and one person shop, then you might want to consider fitting that into some of your appointments with that person, just the first few minutes or the first few minutes of the next few appointments with them, or do it when you're in person with them engaging if you have an in-person visit prior. Okay. So just making sure that we have those types of elements that are documented in practice with them. One of the biggest things is we have seen already some case law that's come out related to privacy concerns and the use of telebehavioral health. And so just making sure that we are aware of that as we're moving forward with engagement and have those conversations with folks. So these are some of those elements where preparing and making sure that we have these pieces is really important. Making sure that we have code words that the individual can use in case they are in an area that something is happening or someone's listening in. Again, there's already been case law related to interpersonal violence or domestic violence and utilizing telebehavioral health platforms and their electronic medical record access to actually engage in further abuse and isolation of those individuals. So that's already been done, and it is recommended to have those code words, etc., so that that person can be able to share that with you to try to identify and be able to change what you talk about or do on telebehavioral health at any time. Okay. Those things are recommended to do obviously in person first, so that you can guarantee the privacy of that person with the original engagement of identifying all those pieces. So just to note that right away. Also, at times, some of those tricks of that are for folks to then turn their computer around or their phone around so you can view what does this environment look like, who is around them, making sure that this is safe for that person. We also want to ensure that when we are meeting with a person and they are doing telehealth, we want to try to identify where they are for each appointment. So that is recommended for our kind of ethical responsibilities. So if they are meeting with you and they're in their car, you might want to say, can you tell me where you are today? Just so that I have that if anything happens today. Just having that information is really important, whether that could be an accident that occurs while they're standing there or an act of violence that occurs on them or any other types of privacy concerns. So making sure that we have that is essential and that is recommended for most of our guilds. So that's another things to make sure that we consider just having in our regular checklist of maybe what we do when we get on a telehealth appointment with someone. We also might want to consider changing or adapting some of our visual aids that we might want to use or tools to make sure that they are approved for different types of cultures, languages, etc. So again, I have more of a list in here. I'm going to keep moving just because of time. We also want to make sure that, again, anything that we're doing, we're looking at literacy level, right? As I'm sure we've all talked about before, literacy levels of the average US American is going to be between 4th and 6th grade. And so So we want to make sure that we stay within that for any tools that we're using as well. So anything that we might be showing or sending to them, whether it be a thought record or whether that be other type of paperwork, we want to consider running that through an age level review. You can do that through your malpractice companies. You can do it through ChatGPT or use AI to do that, but always read it again to make sure that it still is having the same information. And you can actually run it through and have it written twice for people. So it's written in one structure at that 4th to 6th grade level, and then it's another structure of just general, and you have them have both access as well. So those are some of the things that are recommended to really consider. And recommended also is to make sure that if you're using any other app-based technologies or videos, that obviously you run through any types of ethical reviews that you need to do prior to showing those or recommending those with your patients. Some of the engagement pieces that they're really recommending that we start to do is obviously do the same thing that we might do when we're in person, right? Open up the meeting with just doing general check-ins and how they are, making sure that we're doing eye contact with that person that's comfortable for them and what is familiar for them related to that. Also recognizing, is it comfortable that they can have their camera on or not? There are a lot of times where folks will have their camera on for a period of time now, and then they're shutting it off during calls. That can occur within telehealth and still be billable. However, it's really important that if you're going to be doing that, that you plan for what that might look like for that person and the reasons why you might be doing that. And then also consider documenting what that is and the reasons being so that you feel like that is structured and documented well for yourself. As we also want to look at some of the expectations and etiquette, and then we also want to pick very specific types of tools for engagement. We want to make sure that when we're engaging with them with telebehavioral health, we're also looking at maybe expanding what we're doing, trying to do more visuals, open up a whiteboard, be more interactive. And the recommendation is to try to engage that person to do something with you through that visual media and through their device. So whether it be something like, hey, why don't you put in the chat box now? Or, hey, when you're looking at this, what do you think this looks like? So really doing something that has that extra set of engagement with them. What they have found is when we do that extra set of engagement, then they are more interactive and more able to follow through with what we're going to be doing in our general sessions with them. Okay. And of course, that would be true with anything that we do. So just making sure we're kind of, playing off of the general research related to engagement regarding that. We might want to help and have very specific interactive apps where they can click or do a QR code and then they get to type in or do any things as well. We want to personalize content, especially for our teens and kids. We want to explore pets, home environments. We might want to change the background of our own screens so they align with something of their interest, whether it be music, animals, other types of colors, other types of engagements and related to that. It's also recommended for kids that we take short breaks on our appointments where we say, hey, let's talk about this. Maybe it's a goal that we're working on, something else that we're skill building on. And then how about we take a break in about 5 minutes and let's do a laser light show, or let's do this, and then engage them in that, or seek and find. You can do that through the intermedia aspect of your telehealth engagement, which can be really fun for kids and it keeps them really engaged in it. So that can be really great. You can also do the hybrid model. So if you know that the kids are at home or they're at a library, other community system, which often is happening, that you drop off very specific kits there. So then they have their own personal kit. So you can say, get out that kit that you have. Let's go ahead and draw this together. So it's a little bit of a hybrid appointment. So they have something that they're going to be doing that they've received from you or from your clinic system. And then you're going to be working with them through that telebehavioral health session and appointment. Okay. So wanting to make sure that you're really thinking through some of those pieces. Other things that are really helpful is thinking about the use of things like biofeedback. If you are perhaps working with individuals that have anxiety or other types of considerations, maybe you want to consider different types of tools like biofeedback. Or if you're working in an integrated perspective, maybe you're working with individuals with other specific heart conditions or asthma, other related conditions, and you want to use those tools. You could consider dropping off biofeedback materials for them, or are they purchasing their own? It's $20 and under for some of the biofeedback tools that just connect to their own phone, in which case then you can connect together and you can see how they're using a specific breathing technique that you're walking them through is either working or not working, using something like heart rate variability, etc. So you can kind of walk through that with them and monitor that together. And when you see that there's a peak or rise and a change, you could say, hold for a moment. Tell me, what were you just experiencing? Talk me through what just happened. Did your thought just occur? What sensation do you have in your body? And then you can identify real-time intrusive thinking or specific body sensations that might be impeding their relaxation during that time. Again, doing this all through that telehealth lens. So just kind of checking in on doing these pieces. I also recommend really thinking about who your audience is. And if you have individuals that might be experiencing different neurodivergent pieces, that you might want to consider their learning style to be different. You might want to look at how am I engaging with these individuals through telehealth? How am I using the screen differently? How am I using visuals or auditory pieces differently? And how can I be creative with that? How can I use silence as a means of being able to process or help to reinforce skills in different ways with individuals? So just kind of walking through those pieces and thinking through prior to being able to engage with them or having these open discussions with them related to engagement and learning before you have these sessions with them. So here's some more of those adaptation strategies. Now, these have all been research backed as well, even with the use of EMDR and obviously with CBT as well. So there's a lot of great research with EMDR being used through telehealth resources now with significant improvements as well, maintaining. So looking at bilateral stimulations in different ways and also looking at the use of apps, etc. Okay, so just making sure that you consider walking through some of these pieces. I've used things like shared whiteboards. I've used the great video games with kids where I'm actually using heart rate variability video games at real time with them through biofeedback, which has been really helpful. I've also used the times where we take breaks and then I'll do music and light shows and other things that are pre-programmed. And they really have an increased engagement, I find, than when I didn't use those prior. And it becomes almost a reward system for them while I'm working with them in telehealth. So just kind of checking in on that. The other things that are always recommended are things like, of course, engaging with supports and caregivers and considering what you can do in between. Do you have a portal system that you're using? There are some free portal systems and free EHRs out there. Some of them are fairly bad, but there are some that people have used that they like in different ways. So you might want to consider if you don't have that or cannot afford to engage in those, maybe look at some of those free systems, but for a specific element of it, right? And maybe that's just to be able to send them certain paperwork. And so you know that it is in a confidential way, meeting their requirements for our HIPAA and technological exchanges. So just maybe walking through that with that and considering that for yourself. You can also be able to send certain types of text messaging, et cetera, through those. And so you know that you're compliant when you do those. Okay. So here again is just some overviews of some of the ways that you can adapt and engage with individuals. I really love for families being able to map out family systems and really using diagrams to be able to do that. So those are things that can be really helpful, especially depending on what types of perspectives that you have. Really thinking about sharing your scripts or recording some of your scripts or visuals that you might use that then they can have and download and just watch and use and practice from maybe a session that they did with you. So again, the recording would just be on you walking through a breathing technique, maybe that you were doing skill building with them on, does not have them on it at all. So just kind of walking through and making sure that you are using your technology correctly to still maintain confidentiality. Okay? Emotional clarification has a lot of high research and especially being used with not only adults, but also children and individuals that have different developmental considerations. And so this is, again, using pictures, infographics, and really looking at picture use of different pieces related to emotions and different perspectives and experiences. So really consider broadening that piece. Some future directions I want to just kind of close with, and then I'm going to give you all some information of resources, etc., that you can have as well. But just looking at this in different ways, as technology is going to be continually increased. And right now, in almost every state, they already have AI for documentation for not only primary care, all specialties, hospitals, and private practice mental health is also utilizing it. So it is like an Alexa. That's the best way I describe it. But it is sitting in your office. It is HIPAA compliant. It does listen to the entire visit and then it records. Right now, recording and documentation and billing is showing that it has over a 90% satisfaction and effectiveness rate. And that is above what we do as far as our own documentation and billing when we compare our effectiveness rates related to it. I'm not saying or supporting the use of it whatsoever. I can debate this for many reasons and ways. However, it is happening in almost every single state in the United States right now. And so if you do end up using it, you do want to put it into your notice of privacy practices and your consent pieces so that people understand that and are transparent related to what is happening for documentation purposes. That is all AI driven. Again, it is something still that as a practitioner, you do look at and read before it becomes the actual documentation, right? You approve it, you edit it, revise it, etc. But it is becoming much more utilized, especially in private practice. So we're going to see an uptick in that, I am sure, in the next few years, because it is showing that there's a significant amount of time that is being saved for people. And that is done in person and through their online systems. Through the online systems, they're now selling that AI technology through most online platforms that people are using for telebehavioral health. But for in-person, they also have that. And again, like I said, it's being used across the United States and in most places. We also know that the AI technology is also being used in telebehavioral health without us. And so just putting it out very clearly so people understand that. There are lots of chatbots out there that are providing therapy. Okay, as I put that in quotes so everybody knows that. And they are providing that care also for crisis care. And so that is not a person on the other side, that is a chat bot on the other side. It is also embedded in other things like video game systems, etc. With algorithms identifying depression, suicidality, etc., and then providing that level of support to them. So just kind of recognizing that these things are occurring. And what we're noticing is that there's a significant use of these chatbots and AI for our general population, that they are turning to them more than they are turning to us. That is for many different reasons. One is just their use and understanding of technology is just this is what they do. They go to chatbots and AI much more often than they would in person. And second is access. They have immediate access 24/7. And so it is important for all of us to know that and for us to consider adapting questions on our initial kind of in-person interviews or intake forms through telebehavioral health and asking, hey, do you ever use AI technology or chatbots to help you in between visits? Or have you ever done that in the past? What does that look like? So just recommending that you consider adding on some of those questions so that you can help them to be able to navigate that ethically and reasonably for themselves and maybe even utilize that for your kind of homework, other things you might work with them with. But that way, then they have a guide in that rather than just using that without any other types of guidance, but just recognizing it's happening. We do have, of course, our ethical considerations. I put a brief piece here, specifically noting jurisdictional pieces, making sure that we're licensed in other areas or we are part of PACT, P-A-C-T, so that we can do that or that we understand the limits of our work across state lines or across country lines. So just making sure that you walk through these different pieces that might be there. Then I have a couple of slides just related to recommendations that you can read through so that you have it, and then health resources. So these are just there for you with very specific resources and the websites there for you so that you have it if you have any questions. I do want to point out one of the greatest ones is in California. So Dee Dee, shout out to California State again. They have a great telehealth resource center. I do encourage all of you to consider joining their listserv and be attached to that so you can get the up-to-date pieces. And it is all free that they are pushing out. So that's really wonderful to be able to do that as well. So this is the end, and I want to open up to see if folks have any questions.
Great,
Okay.
great
You go ahead,
presentation.
Dr. Antoine.
I was going to say great presentation. I do 80% of my practice through telehealth, so this is really on point for me. And yeah, really no questions, but thanks so much for the information.
Yes, I see here. I was going to say on the chat, some of our participants saying that some of your tips are very helpful. Um, and I also wanted to see if you could share a little bit more about the AI piece. What do you think that people go or tend to go more to the AI or the chat box than to regular people? What do you think is that?
Yeah, I'd love to open up to everyone. I believe it's kind of now just their general like learning. This is what is now becoming every day for, especially for children and adolescents. And we've got that early 20s engaging with AI every day nonstop. In fact, AI is on all of our shopping now. It's actually in video camera systems at everywhere we go, Targets, all of that. It's embedded into Google, right? It's embedded in our phones. It is now so overly embedded that it's everyday life. And so for our younger generations, it's going to be there and it is going to be their everyday piece. And for them, the studies are showing they're not second guessing that. Whereas older generations, we all might think, wait a minute. Um, so I just want to put it out. What are other people's thoughts? If anybody wants to comment on that too.
I think the older generation grew up with Skynet for those who watched the movie, and so that increased the perceived potential harm,
Right.
whereas the younger generation doesn't have that. But we might find out more similar to what's happening with cannabis and other things. It may shift over time.
Yeah. I jest that I was part of Skynet. I, like many, have been part of research with AI, and I was in a team-based research with Arizona State University as well as with ChatGPT, where part of my role was to make AI more human. And so we went through a lot, and it was actually to build very specific motivational interviewing training for them. So the AI bots became humans with backstories, human emotions. And what was very scary for us and interesting is that we didn't give them certain elements that over time they just brought out. So I gave them specific backstories, all that. And then when we were engaging with them, all of a sudden they were like, oh, I'm struggling. My wife is talking about divorce. This is what's happening. We didn't give them that. We gave them other elements, which then they connected that these things would occur if these things were happening. So they brought out larger and larger family dynamics and things based off of lots of things that we fed them. But it was really interesting to see how it grew and changed. And it also, we've had really great research that we've already published on it, how then they would provide mental health trainees on feedback about how they actually met the qualifications related to MI. So the AI chat box did all of the screening related to that. So they went through and gave them all their feedback related to that, scored them, and then gave them information based off of very specific areas, stages of change, etc. So it was really interesting to be parts of that. That research is ongoing with almost every area of therapeutic modality, as well as in assessments. So these are all AI bots doing it, either as a provider or as a patient, so that our mental health providers have more ability to have internships and engagement and practice, but it is with an AI patient. So really interesting about how we're using AI differently and how it's becoming mainstream in universities. And this is where they're going with it. So just putting it out there.
I did have a question. So you mentioned in your PowerPoint, if I heard correctly, is if you're on a platform and AI is being used to document, that information's being sold?
No, 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 no. I'm
Oh,
sorry. Yeah, no, so you can, if you are on an EHR platform that has your telebehavioral health attached to it, most of those platforms now have an AI documentation
Uh,
buy. So you're buying the like basic download or I don't know the best words for that. I probably should by now, but you download that element of your EHR and then that automatically is in the background. Like we have sometimes on Zoom where it's automatically taking all those notes and giving you the summary. It is actually programmed with all of your billing codes for all of medicine, surgeries, et cetera, mental health. And so it knows exactly from the visit how to document that visit, what additional add-ons to do, and then documents it according to those requirements, the legal requirements for billing purposes, and gives you those codes. And so then it'll give you that note at the end that's auto-generated. Then you do a run through and edit it or add what you might want onto it or delete, and then it just goes straight to billing.
wow. Okay, yeah, well, that kind of scared me there. So yeah, as
Sorry.
far as like Chat GPT, I was always so like, no, I don't want to do it. No, I don't want to. But like three weeks ago, I kind of did a little bit. My daughter told me about it, but a few weeks ago, I started like asking it questions, and I'm
Yeah.
like, whoa, okay, like how do, and it just broke everything down for me. I'm like, okay, ChatGPT.
Yeah.
It was, it's kind of, yeah, and I started, yeah, so also like in private practice, and it's a different platform, but I mean, that's not where I'm at today. Today I'm where I'm at today. But yeah, so that was just kind of surprising for me. And I saw that in that platform, it does have the AI option, like to help with documentation. I was so scared to do it. A couple of weeks ago, I did do it, and I find it very helpful, but it kind of scared me. Well, you still have to review it and make sure it's not picking up something that, you know, so it's kind of, but anyway, but that kind of, so it's very interesting. Thank you for this training.
Yeah, thank you. I had the honor to be on a couple presentations internationally related to the AI use. And my colleagues who are experts, I am not. Again, I was just a, the psychologist on board with things. But the AI experts really had great discussions and knowledge about some of the ethics behind where is this information being stored and kind of some of the concerns. And so I learned a lot related to that. And I do think there's a lot to be scared about related to this. As much as it says your information is, private, is HIPAA compliant, it's deemed it, there really is no proof in the end that any of that is true. But we also know there's no proof that your phone isn't listening. There's actually no real information, like from the AI leads from around the world. It was really interesting to hear these things where I'm like, oh, like really? Like so that all that stuff that we're like, oh, I talk about needing coffee, and then all of a sudden there's a coffee ad, right? Everybody has these anecdotal things. It really is interesting of, yeah, actually, we could be doing this all the time and engaged, and we have no ability to really know yes or no on any of that across the board. Um, so just like an Alexa, even though you turn it on, it's always listening, right? And that data is always being fed. Also in your cars, all of that's happening all the time. So if you have a smart car in any way, those video camera systems are always engaged, even inside your car, which is why I don't know if anybody knows the odd studies in that. Again, I can go down this rabbit hole of all the stuff that I learned. But the bottom line is, yes, it is scary, but it's being used. And so if we are going to be keeping up with what this is to engage with, all of the community, we need to be knowledgeable on it, and we want to consider utilizing it in some way, shape, or form. I'll stop because I can keep going, diving down this hole. So thank you. Sorry, Andrea.
No, it's okay. It's a fascinating topic. I understand we could go on and on with this. Anyone else in the, oh, Diana, you wanted to say something?
Oh, I was just clapping.
Clapping. Okay.
Thank you.
Anyone else thoughts that they want to share with us regarding telehealth and
First of all, that was a wonderful presentation. I learned a lot of things that I wasn't aware of. It kind of circling back to, I guess, the question that had been asked is, regarding why um, younger generations might be gravitating towards this modality. I think about, older, I think growing up, we learn like it takes a lot of work to get a conclusion, right? To get to the end. Whereas now's generation seems to be more like immediate. You can, everything is, here's the answer right now. You can literally grab your phone and order food and it's here in 10 minutes, right? So I think oftentimes today's younger generation is looking for a quick fix, a quick answer. So I think that might have something also. And then of course the 24/7 availability, right? It's just like a fast food restaurant right there. Here you go. Quick, fast, easy. That's just my thoughts, my opinions.
Thank you, Elisa. You're absolutely right. It's availability, what makes it also very attractive. I would say it's a great conversation, but in the interest of time, we may quickly move to announcements and then we can move to our case presentation. But I'm sure we're going to have more future sessions about interventions in telehealth, especially related to AI. Absolutely. So remember to claim your CEU, you must complete your post-session survey. Just make sure that you answer yes to the question about CEUs and your certificates will be issued approximately 2 weeks after this session. It's very easy. Next. We're always looking for case presenters. And remember that cases allow us to learn from real scenarios. But most importantly, cases allow us to learn from you, from your own experiences. So we want to hear what you have learned and we want you to share it with us here at this space, at this series. So if you're interested in sharing a case with us, just send us an email at cstat@utesca.edu. Next. Next. And CSTAT offers technical assistance for various substance use disorders needs. To request technical assistance, just complete our TA form in our website and someone will get back with you within 2 days. It's a free service for all of you in the community, so please use it. Next. And the Texas Substance Use Symposium is here again, and we're thrilled to reunite again on March 2nd and 3rd. That's March 2 and 3 at the Henry B. Gonzalez Convention Center. We'll see you there. Please go to our website for more information, more to come. Remember, that's March 2 and 3 at the Henry B. Gonzalez in San Antonio. Next. And on Friday, July 18, we'll have our Texas webinar. Very pertinent, very important topic. Joe Kamola talking about strategies and ways to navigate this new funding policies in this time. I think all of us need to hear about that. If you want to sign up, just go to our website. We're sharing the link on the chat. Next. And of course, next month in this same space for another session on behavioral health echo. And I think that now, Asia, we can start sharing your case form. If you could walk us a little bit through the case, kind of emphasizing a little bit the changes and the progress that we have seen in the case since the last time we talked about this person back in January. Thank you.
Thank you. Sure. So I'll give a little bit of history, since I don't know if everybody was here in the last time we shared about this person. He's a 42-year-old Hispanic male. Some cultural considerations. He is heterosexual. He identifies as spiritual, not religious, though it is pertinent that he was raised in a very religious household. His parents were devout Pentecostal Christians. And the reason that he came to me, he had previously been with another therapist and he wasn't really making much progress. And he continued to slide back into meth use. That was his primary drug of choice. And he had been arrested multiple times. He has a 2-year-old little girl. He lives with his parents, and his parents, helped out a lot with his child. But he once he came to me, we started just working and creating a treatment plan, and he was really able to make some progress, like right off the bat, just through our relationship, our therapeutic relationship. He was able to really open up about his childhood, and I came to understand that he had been sexually abused by a cousin when he was around 7 years old. 5 to 7. And he it came out that what he said that made me kind of consider, that was my first ping when I realized what his current struggle was. I know I'm not making a whole lot of sense right now. So he said that his cousin had sexually abused him, but that he didn't consider it sexual abuse at the time. It felt more like they were just playing, with each other. And then he also said that once this older cousin, who was around 12 years old, I believe, stopped like pursuing him because he recognized it was wrong, or for whatever reason he stopped. And there was this, like, he felt like some disappointment that he was no longer being like pursued. And so as we continued to work together, he let me know that he really struggled with obsessive and compulsive, more obsessions, not really much compulsion. The compulsion would be the drug use, but he said that he had a lot of obsessive thoughts that he may be gay. And I had never like worked with anybody like this. He had been diagnosed with OCD and was actually on disability due to the OCD. But when he started to talk more about the sexual aspect of it, or the like sexual identity, became a real topic that we talked about a lot, because he just didn't understand why he continued to have these thoughts, but he did not feel like he wanted to be in a relationship with a man, or that he wanted romantically to be involved with a man, or sexually, or anything. So that was kind of where I was when I presented last time. He hadn't used. He was he was on 5 years. He just had been sentenced to 5 years of probation. And so he was, having random UAs with his PO regularly, and they all came out, negative. But he just continued to have these thoughts, and it became very clear that it would lead him back to using, because when he used, these thoughts were silent. And so it was a coping mechanism, or self-medication. So that brings us to now. So if you could go back up to the top of the form, please, IT. Thank you. All the way up. Thank you so much. Okay, so my questions at the last meeting was just about I was looking for some recommendations for how to work with him, specifically with this like sexual orientation OCD. I did some research on it. It is actually a disorder that people experience. I found like one psychologist up in New York that worked specifically with it, but it wasn't accessible for him. And so I ended up referring him out to an EMDR / IFS certified clinician, because I really felt like this was out of the scope of my practice. And I wanted him to get the best quality care that he could. And so he began working with her while he was still seeing me. And in March, we went ahead and discharged because the substance abuse had stopped. He hadn't used since like September. He continues to go to recovery Dharma meetings. He loved yoga. He got into yoga. It seems like what he mentioned to me was that the IFS really helped him to be able to like access the younger version of himself and do some healing around like self-forgiveness and just befriending the different parts of himself. He also went through several sessions of EMDR, and that also seemed to help him quite a bit. So let's see. He's whenever I've continued to see him not as a counselor, but every now and then we'll run into each other at a meeting, and he seems to be doing very well. He was able to regain custody of his 2-year-old daughter who had been in a CPS like foster home, but he was able to regain custody, and he's doing very well. He started working full time. Doing some like being a mechanics helper. And I just think sometimes I thought it was important just because I think a lot of times we focus on not that, CBT and motivational interviewing is excellent, but also sometimes there's other modalities that we can look at, especially with these like high acuity people that have like severe substance use disorders. There's often, trauma underneath, and being able to pair him with a therapist that could really work with him on a deeper level was really helpful. So as far as the medications go, that was something that he actually was talking about before we stopped meeting. He was wanting to get off of the medications, and I was a little hesitant, but it's his treatment. But I explored it with him, and he just said that he'd been on medications forever, like his whole lot, like since he was a teenager, and he was concerned about the impact that they would have, long term. And so he decided that he was going to speak with his psychiatrist, and they have titrated him. I don't know if he's completely stopped, but he seems to be doing fine. He's titrating now. So
In the sake of time, I'll jump in with some thoughts initially. I'm just saying great job with all the just engagement that's going on. I know it's not as frequent as it was before, but the fact that you're still connected, I think it's a great thing. Harkening back to the presentation, something I often do is something called the Yale Brown Obsessive Compulsive Scale. And I've given that even over telehealth. So a person fills it out and we talk about some of the interesting things. I'd be curious, as this person has backed away from medications, whether that scale has gone up or down or where it might be, just to increase engagement, as Dr. Manson brought up, and have a conversation about what might need to change or not need to change, depending on what's going on. But a lot of great work there, and I'm glad to hear a positive change over the year plus. So thanks for that.
absolutely, thank you.
Thoughts
I'll just jump in and
from the
say,
group? Yes,
sorry,
go.
Andrea, just to say that one of the things that I think you talked about, Asia, that's so important is the idea of referring out. And I always like to say the more people in the pool, the better, almost always. I'm really good at a piece or two over here, and other people are going to be better at their pieces. And that's great. It's all about client care, right? So well done. And I know it can be difficult to make that decision.
Yes, yeah.
thoughts, questions? Isha, if you wanted to talk a little bit more about this new therapy that not new for him that he tried that apparently worked really well for him, the
Mm.
EMD.
The internal family systems or the EMDR?
The EMDR and then
Yes,
the other one as well.
yes. Well, I wasn't the one that practiced with him, though we did do a little bit of inner child work when he was here, which was again why I thought, well, you would do really well with someone that was really skilled at this, because I do a little bit of parts work, but I'm not certified or anything. So just being able to, because a lot of times I think what happens is we have like this internal family within us that another word for parts, like different parts of us, and sometimes when trauma happens at an early age, um, there's like the inner child kind of gets into this sort of role, whatever it might be, that acts as kind of a defense and creates conflict within. So, there's somebody else wants to speak to it, that would be great. If anybody else is familiar with IFS, but it helps to bring the adult self. That's the self is with a capital S. IFS was founded by Richard Schwartz. He has a great book called No Bad Parts that I haven't read. I've read parts of it, but I saw him give an interview on it, and it's fascinating. Just being able to find like forgiveness and like harmony between the parts of ourselves instead of kind of being at war with each other. If that makes sense.
You're doing a good job of explaining it.
Thank you.
Yeah. And the inner child,
Yeah.
well, the inner child work actually came out of the 80s. That was John Bradshaw that first started talking about this inner child. If anybody who watched PBS back in those days would have known John Bradshaw. And I studied with him a bit.
Oh, wow.
And then there's another person who's a colleague and friend of mine, Scott Kellogg out of New York, who does something called chair work. And where you're talking to a chair that is representation of other parts of you or people in your life. So, there's a few of them out there, a few modalities out there that can explore that. So again, it sounds like you started that process and he found that useful. And so now, with that knowledge, you can make a great referral. Yeah. Yeah. Nice.
Questions or ideas from the group?
I actually wonder how often folks in the group utilize or collaborate related to treatment. So, do other folks do collaborative treatment? And, either it's I engage and I'm talking with that other provider a lot, right? Or, maybe it's referral out for a period of time and then they return for something else. So, I find it's much more popular in specific areas, especially when it's sometimes more rural, sometimes more in larger cities, right? Depending on what you're doing. But just out of curiosity, if folks are doing that more often and thinking about that.
Most of my folks come from elsewhere, whether it's from OBGYN doctors or psychologists. So most of my care is elsewhere, and I'm often the transient person that I send them back. The part that I wonder whether it could be done better on my end or others is how to, frankly, bill for that and make it sustainable financially, because there are opportunities that aren't capitalized on with what's coming with our regulatory things in October. There may be more opportunities or less opportunities, but I think there needs to be more awareness of how to build for that collaborative care model and make it more sustainable. But I found it essential for my work.
Yeah, same. I work in an integrated clinic with medical and behavioral health, and it's been very helpful to be able to speak with and staff cases, together, whether it's me and another counselor that I'm doing the substance use piece and they're doing the the anxiety piece or whatever, even though they really go hand in hand. Um, but just being able to have that level of quality care on behalf of the client, I think is huge.
That was really speaking to the whole point of becoming behavioral health. When we went from separate mental health, substance use, and whatever else, if there was another one in some places, and becoming behavioral health was supposed to help us to integrate. That has been mildly successful in some places, wildly successful in others, and somewhere in between. But it is that idea that if we all work together, kind of like that wheel and the spokes, sometimes we use the hub and spoke model, that can be much more advantageous for the client, but also for us. I love it because now not all the pressure is on me to know every aspect and to be responsible for every aspect of this person's care if they have a great deal of complication.
Thank you, Dee Dee. And we're close to the hour, so in the interest of time, I'm just going to allow Lesley to give us a little summary of the session and some recommendations or ideas for our case presenter today. Lesley.
Yeah, thank you. So really I'll just speak as quickly as we can, we're over time now. We did a review of some engagement strategies for telebehavioral health, also discussed some important pieces to consider embedding into what we do normally for practice or do for consent with the folks that we're working with. And then as far as the case, I think some of the big things that were brought up is really looking at how we can diversify our modalities, working collaboratively with others, and meeting the person where they're at and taking it slow, not making assumptions when it comes to cases, and working with them to be able to explore and move them forward. I'll just put it in that way as fast as I can and close up. Thank you, Andrea.
Thank you, Lesley. And once again, the material is going to be sent to all of you along with the post-session survey. Make sure, please, that you answer that survey. Thank you to all of you. This has been a great session, and we'll see you next month. Bye.